Good evening. Welcome to Health Plus Weekly. I am Dr. John Podkowa, joined with my co-host, nurse practitioner Hannah Raymond, and it is good to be back. We missed you guys last week. Hannah and I had a conference that we had to attend to, so it's nice to be back. We are lucky tonight to have pulmonary and critical care specialist Dr. Michael Barretti here on the show this evening. Mike, thanks for coming out for the hour.
Thanks for having me.
We appreciate it. We'd like to hear from everyone, where everyone's watching from tonight, and if you could kind of tune us into what you're doing for your healthy activities now that the weather is finally turning nice. Are you getting outside? What are you doing to kind of shake off those winter kind of doldrums and enjoy this finally some nice weather? So if you could let us know, that'd be great. Before the show gets started, we have just a couple things we want to make sure we mention. This is National EMS Week, and we'd like to thank all EMS providers who service the South Coast area for what they do day and night for transporting our patients back and forth to the hospitals and to appointments. We absolutely depend on you, our patients do, and we're grateful for the tremendous amount of service that we have available in this area. So thank you to all EMS providers. May is also National Speech and Hearing Month, so we want to make sure that people know how important it is to have your hearing evaluated in your speech, and if you're having any difficulties with that, you can go to our South Coast Facebook site or our website. We have several great ear, nose, and throat locations and doctors and teams who can help you if you're having speech and hearing problems. And finally, just I want to put the plug in now tonight, but also at the end of the show, Dr. Barretti is our guest tonight, but he'll be speaking Wednesday, June 27th at the Fairfield Inn in New Bedford on MacArthur Drive. What's the topic of that talk?
Severe asthma and bronchial thermoplasty.
Oh, great. So we'll talk a little bit about that tonight, if that's okay with you.
Absolutely.
Good. We want to encourage everyone to send in questions via Facebook, please. The show is great when we interact with you guys. We'll hopefully get a lot of questions regarding asthma, COPD, and other topics pertaining to lungs for Dr. Barretti, but also Hannah and I are, and you as well, because you did some primary care in your past, so we're welcome to take some primary care questions as well.
That'll be, yeah, we'll see how shake off some rust a little bit there.
Absolutely.
Right?
We'll see how that goes.
Yeah, right. And we should say that you are on call right now, too. So
I am. I apologize in advance.
Really on call.
It's already gone off once. Yeah.
So we usually ask our guests to just give a brief kind of introduction to themselves about, how you wound up in medicine and especially in pulmonary medicine, and also what brought you to the South Coast area.
Sure, great. So, born in New York, raised in central Massachusetts.
Okay.
My mom was a medical secretary, so I spent a lot of time around the office,
yeah,
hanging out with the doctors, and I think that's what kind of got me into medicine. After medical school, I kind of fell into pulmonary medicine through critical care. It's a combined training program, and critical care is kind of where my interest lay, and then to do that you do pulmonary, and then I end up practicing pulmonary as well as critical care. Coming down here, beyond my critical care and pulmonary work, I did interventional pulmonary training, and this is a very unrepresented area for interventional pulmonary. In fact, there's not an interventional pulmonologist between Providence and Boston.
Now there is.
Now there is, exactly.
With you,
so
right?
it's been about 4 years.
So what does that mean, interventional pulmonary?
So beyond the typical pulmonary care, outpatient, inpatient, we do the advanced bronchoscopic and pleural interventions, not just the standard bronchoscopies, rigid bronchoscopies, navigational, endobronchial ultrasounds, chest tube pleural interventions, percutaneous tracheostomies in the unit, and whatnot. Wow. So we're busy. There's a lot of work for that down here.
And then, so in case someone's out there who's questioning and just making sure they understand, so pulmonary means all diseases affecting the lung. Just
yes.
You know what I mean? So, that's what your emphasis is on, and kind of diseases affecting the lung, except outside of the critical care arena where you manage. I always think about critical care specialists are almost like primary care doctors in an acute setting where you manage almost all the organ systems and kind of take care of the whole patient while they're in the intensive care unit, correct?
Yes, yeah, it's the sickest of the sick in the intensive care unit. Yeah. It's usually end stage everything. They show up in the ICU.
So you split your time between inpatient in the hospital and outpatient in the office?
Yes, about half my time is in the ICU, and the other half of the time is in the office or the OR.
Great.
And you see patients in Fairhaven, where where Hannah and I work? Do you have any other clinics, or is that?
Nope, just Fairhaven right now.
Okay, great.
Yeah.
And part of your training, you were in the military, correct?
Yes, I was. They actually paid for medical school.
How did that work?
So it was, well, I needed someone to pay for it.
Yeah, exactly.
And in 1999, that seemed like a really easy gig to do. My dad was career military. He was a 20-year Marine. And I told him that I was considering the Navy scholarship, and he said, "Are you sure you really want to do that?" And I said, "What's the worst that could happen?"
Well,
I found out. So I went through med school, and then obviously 9/11 happened, and the game changed. And they let me do 1 year of civilian postgraduate training afterwards. I did it up at UMass, a 1-year internship in internal medicine, and they said, "Come with us." So my detailer called me and said, "Where do you want to go for your first tour?" He said, "We need a general medical officer," because I'm really not trained for anything after 1 year of internship. And I said, "Well, I'll make it easy for you. Send me on any ship anywhere in the world." And he said, "Okay, well, how about the 2nd Marine Division, Camp Lejeune?" I said, "No." "How about any ship anywhere in the world?" And he said, "Oh, okay. How about the 2nd Marine Division, Camp Lejeune?" So
a lot of compromise
the rest
there.
is history.
Yeah.
Yeah, the rest is history. I got an infantry battalion of about 1,200 Marines, and I was the doc.
no kidding.
Yes.
1 year training.
1 year
1 year
training,
training.
and you're the
You
battalion.
were ready.
You're the battalion
You
sergeant.
felt ready.
No, they give you about 3 months of trauma training,
They
split
did.
up over some different areas, and really some of the most hardcore training you could imagine.
I bet.
It was.
Is that where your love for kind of the critical care
Yes,
aspect came from?
absolutely. It
Yeah.
is. It
Yeah.
really is.
Yeah,
It really
that
is.
must have been amazing, actually, in terms
It
of-
was trial by fire, then it was a deployment to Iraq, and the next nearest doctor was a helicopter flight away. So it was everything you could carry on your back or in your trucks and use it there.
Are you still in the military? Are you?
I just recently got out. I went from active duty to the reserves and spent a lot of years in the reserves, and with my lifestyle now, it just doesn't.
Yeah.
I have 3 little kids.
Sure.
And I do 2 weekends a month at the hospital, and to do another weekend a
Away.
month away that doesn't work anymore.
Wow. And how did you find Southcoast, if you don't mind me asking? So,
So I knew some people down here, actually,
Okay.
that came from UMass, and Craig Longo, one of the ED physicians,
Sure.
was down here, and I knew that they needed an interventionalist in this area.
that's great.
Yeah, it was great. It worked out very well.
Yeah, I know. I mean, from taking care of our patients, it's a tremendous resource to have you locally for, some of our patients with lung cancer who need procedures done and other things and not have to go, travel. It's such a great resource. And have you been busy? Has it been?
Very,
Yeah.
very. From the second I got here, I was packed in clinic and procedures coming out of my eyeballs. So it's been a really good experience.
Good. So on this show, there's certainly some of the more critical care things that come up, but the focus is more on some of the long-term chronic issues that we see more in the community. So they cross paths with you probably most often in the clinic, but certainly, during an acute exacerbation in the ICU as well.
Absolutely.
So, top of the plate right now is asthma.
Yeah.
We're all seeing a lot of that, talking before about like the allergy season
Yes.
is in full swing now, and a lot of asthma exacerbations. So
Absolutely.
could you just explain what is asthma?
Asthma. Asthma is a reactive airway disease with a very strong genetic component, a very strong environmental component, with as many different phenotypes as there are genotypes. So everyone's got their own individual asthma. Our airways, the way I tell patients in the office is our airways only know how to do one thing when they get angry, and that's squeeze. And that squeezing of the airway is what creates turbulent airflow, and the turbulent airflow is what we hear as a wheeze.
So kind of that musical quality if you've ever been sick.
Exactly. The wheeze is nothing more than a turbulent airflow through small airways. And that can be in response to any number of triggers. It can be from cold air, from exercise, from infection, from allergies, from postnasal drip, from acid reflux, from stress can cause people to have asthma exacerbations.
So that's what you mean by everyone has their own different type of asthma?
Everyone has their own type, exactly.
Okay.
So
some people have a genetic component to it as well. What are some of the...
very strong genetic component to asthma in families.
What are the things that people will look for? Just other members with...
Members of their family with asthma. Allergies and eczema are actually the 3 atopic conditions that we see most oftenly linked. Not everybody gets all 3. Some people get 1, 2, or the unlucky ones do get all 3.
Yeah.
But it's essentially the same immune phenomenon happening in 3 different ways.
It's kind of this hyper-reaction or this exaggerated reaction to things that normally wouldn't bother people, so they get their eyes run and they're more sensitive to certain things, and then their skin.
It's almost a ramped up immune system and hypersensitivity reaction.
So what actually goes on in the lungs to create that term? You said the lungs squeeze and do one thing, but
Sure.
there's kind of 2 different underlying pathologies that we generally know how to treat, but what are those things?
So in asthma, the hallmark of asthma is bronchoconstriction or airway narrowing. The airways have a smooth muscle layer in between the mucosal layer and the connective tissue layer, and that smooth muscle layer, when it gets angry for whatever the stimulus is, squeezes and narrows the lumen of the airway, and that's what causes the wheeze. So that's the main trigger. That's I would say the common end pathway for all asthma exacerbations is smooth muscle squeeze and airway narrowing.
Okay. And some inflammation, is there inflammation in the airway as well, or is it mostly just the smooth muscle?
There's an overlap. There is an inflammation in the airway. The submucosal layer gets infiltrated with neutrophils or eosinophils, depending on the type of asthma.
Kind of reacting to the trigger. Gotcha.
Exactly.
Is there so age and gender in terms of, are men more susceptible to this, women, and does it change by age?
Good question. Age, no. You hear people that have childhood asthma that grow out of it. You have people that get asthma for their first time in their 80s.
They do, so that happens.
Yeah, absolutely. And they look at me when I tell them in clinic, and they're like, I've never had asthma before. And so, do you have any relatives with that? Yes, everyone in my family's had asthma, and I've had eczema my whole life. So,
and it can happen.
Well, now you get asthma. It can come and go over the years, and a lot of times we see it wax and wane with allergy symptoms, with environmental triggers and whatnot, with work exposure. Strong perfumes, smoke at work, or secondhand smoke, or smoking in a patient themselves. I think that males are more susceptible to asthma by the numbers. I'm not sure if that's a reporting issue, or if it's chalked up to something else. But and the ages can wax and wane. I see patients develop asthma for the first time, or clinical asthma for the first time at any age during their life.
Besides a family history of family members who have asthma, risk factors for developing asthma, smoke exposure, correct?
Smoke exposure.
And possibly even like if your mother smoked while she was pregnant with the, right?
Yes, absolutely. Absolute maternal smoke exposure while in utero. Secondhand smoke is a big one. Obviously primary smoking is a bigger one. Occupational exposures. We see patients with occupational asthma where they have asthma symptoms Monday through Friday.
At work, right,
and they go home for the weekend and they're fine, and then they come to see me and they can't figure it out, and then they go back to work and they're sick again. So that happens as well. But
what about weight and obesity? What's your thoughts on that?
Yeah, so that I consider to be a subset of asthma.
Okay.
Well, it is entirely possible, and it happens all the time, that overweight people have the same genetics that regular people do, and they can get asthma just like non-obese people can get asthma. There's a phenomenon called tracheobronchomalacia that we see far more in obese patients than we do in non-obese patients, and this is an asthma mimic diagnosis. So these are the people that go to the emergency department or go to some of their primary care physicians or walk in clinics wheezing, and they have trouble breathing, and they get put on steroids. Inevitably, someone says, okay, quick fix, take your prednisone and go home. Maybe they've gotten the quote-unquote diagnosis of asthma in the past, and then it becomes a self-perpetuating issue. Now they have this diagnosis of asthma, but every time they feel short of breath with obese people is quite often they go back to their physician, whether it be an ER, primary care, walk-in, or whatnot, get more prednisone. It's not fixing the problem.
No.
The back of the airway is floppy just from obesity. And
so the actual body habitus,
the body
weight
habitus
of the body
is created so our tracheal rings don't go all the way around our trachea. Our tracheal rings only go about 3/4 of the way around. And then there's a soft membrane behind it that allows it to flex for air movement. Well, what happens in tracheobronchomalacia is those rings stretch, the airway then flops and occludes the airway, narrowing the airway, but not from an asthmatic component. But if you give someone like that prednisone, they're just going to gain more weight, and they're going to get worse tracheobronchomalacia. So it becomes a self-perpetuating issue, and it's very tough to treat. Now, those people can have asthma as well, and that becomes exceedingly hard to treat.
Right. So it would be important in somebody, kind of a obese or overweight person who just doesn't seem to be getting better, treated for asthma exacerbations all the time. Would you recommend having testing to confirm asthma or disprove it?
Well, testing.
I think it's a really good point in terms of when we talk about making sure you have the right diagnosis, because this is something that happens with people with lung disease, whether I have asthma or I have chronic bronchitis or I have emphysema, and you can get down treatment pathways and maybe receive therapy. Things that, as a pulmonologist in your clinic, you do is how do you make these diagnoses, and how I think it's really important that we talk about that, right? Making sure you actually have the right diagnosis. So if we're worried about you have asthma, so if you wheeze or if you cough are kind of the big symptoms of asthma, right? So make people think about, oh, maybe I should be evaluated for asthma? I mean, what are the symptoms?
Well, anybody that's having unexplained shortness of breath, coughing, wheezing, will go through the primary care pathway, and the primary care physicians, like yourself, are fantastic at diagnosing the vast majority of these based on pattern recognition and common symptoms. And when common things are common, they can be handled in the primary care world. When they become uncommon, that's when subspecialty consultation can help out and fill in the gaps. So the first thing is, do they have risk factors for COPD? Do they have occupational exposures? Do they have wood-burning stoves at home? Are they from a third world country where all their cooking gets done with biofuel at home in a closed environment? We actually see a huge number of females with COPD from third world and non-first world countries just from biofuels in the home.
Wow.
Are they smokers? Do they have secondhand smoke exposure to the occupational exposures? If you don't have risk factors for COPD, it's very hard to develop COPD without something called an alpha-1 antitrypsin deficiency, which is a different ballgame altogether.
Yeah.
So then we say, okay, do you have the asthma genotype? Do you have the asthma phenotype? Are you wheezing? What are your triggers? What makes you short of breath? And do they fit that asthma mold? Do they have one of the commonly known triggers? Have you ever been given a diagnosis of asthma as a kid?
So if somebody says, oh, every time I run outside in the cold weather, I cough, 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 and
I rarely even get pulmonary function testing on those people. I say, guess what? You have asthma.
Yeah.
So,
or every time I get a cold, I cough and wheeze for weeks afterwards.
Absolutely.
Yeah.
And the most common complaint is, and I hear this all the time, and they should just tell the people to make the appointments this and not even come to see me because I can prescribe it over the phone. I get bronchitis the same time every year. Well, no, you don't. You get your asthma exacerbation when the weather changes the same time every year. Every time I get a cold, it goes right to my chest. Okay, great, that's asthma. Those are the two most common things that people come in and say. And asthma is not a black and white diagnosis. Asthma is a spectrum. There's the people who get the exercise-induced or the cold weather or the childhood asthma, all the way through to the people who can't go from here to there without 6 inhalers. That's obviously the more concerning asthma, which is where we're going to talk about bronchial thermoplasty, but anywhere in that you can fall and you can change your spot in that year to year or station to station during your life. It can vary.
That's amazing. It's really interesting because we see so many people who say that, so those things, just what you said, every year around this time of year I get bronchitis. Or what's increasingly happened in my time seeing patients here, I'm not sure if you're seeing this, Hannah, but after an upper respiratory tract infection, there's an increasing number of people who just persistently cough for like 2 to 3 weeks after or more, you know what I mean? And they're kind of frustrated. They want more antibiotics, but kind of talking with them and realizing that it's just this hyperactivity, or the lungs just being revved up and getting them to, take an inhaler for a period of time until it calms down. But it's super common.
It is. And it's more common in this region of the state than it is almost anywhere else in the state of Massachusetts.
No kidding.
Is there any particular reason for that you can?
High rates of smoking, a lot of industrial work, and I think genetics is going to have a lot to do with it at the end of the day. But the southeast region of Massachusetts is one of the highest prevalence for asthma in the state.
Oh, okay. That makes a lot of sense.
So you said there's a spectrum of people with asthma.
Yes.
So there's the walking, talking, pretty easy, happens once a year. And those people, so there's a variety of different things that we can use in the primary care field to kind of treat them and manage them forever without an issue.
Yes.
Those are the inhaled kind of steroids that act as controller medications. There's some of the bronchodilator medications like the albuterol that people use. When does it come out of our realm and into the more specialty realm? Like when would you want to see somebody with asthma?
Sure. So there's a stepwise fashion for treating asthma. We call it the step up or the step down approach to treating asthma. And you can classify asthma in the mild intermittent asthma,
which is the
mild
least
persistent,
severe,
the moderates, the moderate persistent, the severe asthma. And really putting an exact name to it isn't as important as how people are responding to the therapy. So if someone comes to you and says, I wheeze when I walk out in the cold, or I get a cold and it goes right to my chest, or I get bronchitis the same time every year, well, how are you the rest of the time? Oh, I almost never feel any problems. Are you waking up at night with the symptoms? That's a big one, nocturnal symptoms. These are the more serious asthma concerning symptoms that would probably prompt a pulmonology referral. But to start out with just a bronchodilator as needed, like albuterol, what people call their rescue inhaler, or their little red pump, and teach them how to use it properly. That's the
when
biggest
to use
problem.
it.
Yeah.
When to
Yeah,
use
yeah.
it, how to use it properly.
Yeah.
People spray it in their ear, in their eye, everywhere but where they should get it down. I mean, they hit their tongue with it more often than not. Try giving an 85-year-old an inhaler for the first time and tell them they have to breathe in and hit it at the same time and get it down. No, it's not going to happen. Spacer devices help, or some different delivery systems that we have now. So starting out with a simple rescue inhaler and see how often they use it. And I tell people, if you're using this a lot, we have to step up the treatment. And then I have to qualify that statement because they think that they're not supposed to use it. So they go home and have a ton of symptoms and don't use the inhaler.
Right,
Yes.
right,
And they
right.
come back in and I say, well, how often did you use your rescue inhaler in the last month? Well, you told me not to use it. I said, no. I said, use it as much as you need it, and I'm going to work around that to make sure we're doing the right thing.
Right.
And if they're using it, more than twice a day, more than multiple times a week, any nighttime symptoms, probably stepping up to the inhaled corticosteroids.
I think that's important. It's just an important message to get out there for people to understand too. So if you have like a short-acting or an inhaler that makes you feel better right away, you shouldn't be using it multiple times. Multiple times a day. If you shouldn't, if you feel like you're needing it,
You shouldn't be needing
You
it.
shouldn't be
Needing it.
needing it.
Yeah.
Exactly.
Right, like that. You shouldn't
Yes.
be
That's the
needing it
difference.
3 to 4 times a day. You know what I mean? And
Yes.
and if you need it, take it without a doubt. We want you to take it, but if you need it 3 or 4 more times a day,
Then
or
we're
multiple
doing
days a
something
week, then you need more help, right? Like come in, let's get checked out, see your primary care doctor, maybe the pulmonologist, but we can make you feel better, right?
Absolutely.
You shouldn't be feeling like that.
Absolutely, absolutely.
Yeah.
So I tell them if they're using it too much, it's not their fault, it's my fault.
Right, I like
that's
that.
great. Yeah.
Exactly.
Yeah.
I'm not doing my job correctly if they're reliant on their rescue inhaler. I also tell them to use it preemptively. If someone knows that exercise is their trigger, take a couple of puffs before you work out. And that really helps people. If you're
Yeah.
going out in the cold air to shovel snow, take a couple of puffs before you go shovel the snow. And then they really get a lot of benefit from that.
Yep.
So, and then the combination medications, the inhaled corticosteroids, the long-acting beta agonists. Now we're using Spiriva, the long-acting anticholinergics for asthma as well. Those were approved for that. And then we step up all the way, and then we're talking biologics, Xolair, Nucala, and then bronchial thermoplasty, which is now competing, and rightfully so, with the biologics for the severe asthmatics.
So what qualifies, describe the symptoms of like a severe persistent asthmatic
A severe
patient.
persistent asthmatic is someone who is nearly always in the throes of an asthma exacerbation. They are on maximal therapy. They're on inhaled corticosteroids, long-acting beta agonists, usually the long-acting anticholinergics. They may have tried a biologic in the past, or may have not qualified for a biologic based on their immune profile, which is one of the blood tests that we check, or they're getting frequent prednisone prescriptions, frequent emergency room visits, still getting nocturnal symptoms despite maximal therapy. These all qualify as the severe persistent asthmatics.
And as you said before, nocturnal symptoms, nighttime awakenings is one of the more kind of ominous
Concerning.
predictors of, your outcome from asthma.
Absolutely.
The maximal, the lungs are most bronchospastic naturally between, I think, 1 and 2 a.m.
With the
So if
diurnal
you're-
rhythm, yeah.
So if you're having symptoms with that kind of natural change in your body, that is concerning. So,
It is, absolutely.
So another PSA, we always try to, things we wish everyone knew.
Yeah,
about-
at night, yeah, absolutely.
So, yeah, these people wake up in the middle of the night and they sit in the corner of their bed and they wheeze and they
Yes,
cough,
yeah.
and there's the cough variant asthmas, which is a different story.
Yep.
And they're hitting their inhalers all night. They're using nebulizers at home around
Yeah.
the clock. And they're doing everything they can just to hang on.
Right.
And from a lifestyle standpoint, a lot of them don't even realize how much this is impacting their quality of life.
It's
until
just
you
happening slowly,
point it out
right?
to them. It's the frog in the boiling water analogy. You know that analogy? Okay. So if it happens to you slowly over time, you don't realize how sick you're getting. If it happened to you all at once, you'd be screaming from the rooftops. But
Yeah.
over time, you tend to adjust around it. I don't go out when it's cold anymore. I don't shovel my snow. I can't go out in springtime when the allergies hit because my asthma. And you point this out to them and say, you're not doing a lot of things that you normally would do. Do you think it's because of your asthma? And I say, well, yeah, actually, now that you mention it. And then they realize it, the light bulb goes off, and they realize how limited they are because of poorly controlled asthma.
But despite being on all the appropriate medications.
Absolutely,
Yeah,
absolutely.
yeah,
And compliance is a big issue.
Yeah, yeah.
And we have to stress with them how to take your inhalers, when to take them, the difference between your rescue and your controller inhalers. And
So that's the type of patient that would be a candidate for the bronchial thermoplasty. What is that procedure?
All right, so bronchial thermoplasty is in the vicinity of 10 years old from its inception. It's the first and only non-pharmacologic therapy for severe persistent asthmatic patients.
Not a drug, not an inhaler.
It's a one-time non-pharmacologic therapy for the most severe asthmatics that are still having symptoms despite maximal approved medical therapy. Okay, so this involves 3 procedures, each separated by about 3 weeks.
Okay.
Where we do bronchoscopy, which is a flexible scope under general anesthesia. Usually, you can do it under moderate sedation. We tend to do it under general anesthesia. It's a little more controlled. A flexible bronchoscope into the lungs, and then sequentially over those 3 procedures, targeting different areas of the lungs and hitting every single airway that we can get to with a little catheter that applies radiofrequency heat energy to the airway wall. Now what that does, it actually shrinks the smooth muscle layer that I spoke about before.
Okay.
Think of the smooth muscle in the airway as like any muscle in your body. The more it squeezes, the bigger it gets. And asthmatic patients are constantly squeezing their airways. That muscle is getting bigger and bigger and bigger, and if you can imagine, it's over time narrowing the normal lumen of the airway, and then each asthma exacerbation you get after that is even worse.
It's worse, yeah.
Because the airway starts out smaller. So
Okay.
this radiofrequency heat energy on pathologic slides all through the testing of bronchial thermoplasty is shown to reduce the volume, the mass of the smooth muscle layer of the airways and make it less reactive.
Okay.
And it doesn't damage the airway, the
Not at
actual
all.
airway.
No. I mean, there's a misconception that we burn the airway, and we're absolutely not burning anything. It's a low-level radiofrequency heat energy applied to that layer in sequential fashion that shrinks it over time.
Is this for adults, for kids? Because kids, both adults and children are afflicted with asthma. So
Absolutely, it's approved for age 18 and over right now.
Okay.
Yeah, so nobody under the age of 18 will qualify for it at this point.
Okay. And do you go 3 times? Do you do a section of the lung each time, or do you do, how does it, yeah?
So because it is heat energy, it does cause a level of inflammation in the lungs. Doing the entirety of both lungs in one procedure would cause a lot of inflammation and a lot worsening of their asthma temporarily. And I tell patients when they're going through this, there's a lot of patient education that goes into it and prep work before the procedures. I explain to them, you're going to be on some prednisone all around this time period that we're doing these procedures, and you're going to feel it. I said, after this first procedure, you're going to feel a slight worsening of your asthma that we're going to manage well with prednisone, and you're going to be using your inhalers and your nebulizers, but expect it to get a little bit worse before it gets better. And we target one of the lobes at the first session, another lobe at the second session, and then the 2 other biggest lobes in the third session.
Okay.
There's one little other small lobe we don't touch.
Okay.
Doesn't really participate much in it.
When do people start feeling better?
Good question. Some people get benefit after the first procedure. They notice a significant improvement in their breathing, even just after treating one lobe. We tell them don't stop, keep going for the rest of them. Some people after the second procedure, most people after the third procedure.
Great.
And then it's a little bit of time after that, several weeks after the third procedure, we wean off those steroids and they feel that improvement over the next several months. They just keep feeling better and better.
Great, great. I think we actually have a little video to show
Perfect.
of the actual procedure. So if you want to cue that up, Josh, and then we can talk a little bit more about kind of what the longer term aftercare looks like as well.
Okay.
Here we go.
So this is a animation of the lungs, and you can see the cross-section of the airway. That dark red circle in the middle of that airway lining is the smooth muscle layer. In asthmatics, you can see it gets bigger over time, and the narrowing of that airway lumen. And then you can imagine every asthma exacerbation after that causes further narrowing and then further smooth muscle hypertrophy or growing of that muscle layer. There's an asthma exacerbation with the inflammation and even more narrowing of the airway. So that's a severe asthmatic airway right there. This is a description of the procedure with the bronchoscope advancing into the airways and then targeting that right lower lobe. And then through the bronchoscope, we advance a small catheter called an alair catheter with 4 little metal probes on it that literally just touch the airway and apply heat energy, radiofrequency heat energy, to the airway We start all the way at the end and we pull back to touch every bit of the airways we can see. So apply some heat, come back, apply some more. Each procedure takes on the order of 45 minutes to get all the airways in each of those lobes. Persons under general anesthesia, just for about 45 minutes to an hour tops.
Is it a same-day procedure, like they go home, or do they have to stay overnight in the hospital?
It is. So it is an outpatient procedure. A lot of the ones we've done, we do offer the patients an overnight stay afterwards, especially if the patient lives alone or lives too far from a hospital for their own comfort or for my comfort. Because if they go home and end up with a severe asthma exacerbation, I want them in a close environment. So most of the people I've done this on have actually spent the night in the hospital afterwards, and the next day they feel great and they go home.
You do this at St. Luke's?
Yes, St. Luke's.
Great.
So then, do typically people still require some of those long-term controller medications afterwards?
Yes.
But at least their symptoms are better controlled and they can do more of what they
Exactly.
want to do.
So it's not a cure for asthma, and that's an important point. It doesn't cure people of asthma.
Okay.
What it does is take someone who's fallen off that dose-response curve of their asthma controller medications and puts them back on the curve. Where they get an appropriate response with an appropriate medication.
Great.
So it doesn't replace your inhalers. Some people do notice less of a need for their inhalers, but we don't tell people at all to expect to come off their inhalers. We tell them that we can probably get you off your chronic prednisone, we can get you out of the emergency room, we can get you back to work and back to school with fewer missed days, and we can get you an improved quality of life. And these are the indications that actually bronchial thermoplasty was shown and proven to achieve, or the outcomes they were proven to achieve. And the most important one would be the quality of life. People with asthma, we have a validated questionnaire for asthma quality of life, and it shows that after bronchial thermoplasty, in about 85% of patients, they get a significantly improved quality of life.
That's great. Can it be repeated?
No, it can't. It's
So
a
it's a
one-time.
one-time.
Yep. And the effects are shown to be persistent. The latest data we had was, I think, a 7-year study that came out that showed the positive effects of bronchial thermoplasty were carried through the entire length of that study to at least 7 years. And I think I'm not sure if I'm at liberty to say this, but the newest data for about 10 years out is about to be published.
Good.
For persistence of this effect.
That's wonderful.
Is it part of a study at all that you're doing here?
Nope, it's not part of a study. This is approved. This is paid for by insurance companies.
It is. That was my next question. So insurance companies are paying for this?
So it varies. It's still 10 years old, is still considered new in the medicine world. So it's come a long way from when it was first approved, FDA-approved treatment, to actually be covered by most insurance plans. Massachusetts, we're lucky enough to actually have the best insurance coverage for bronchial thermoplasty in the country.
That's great.
Yeah, we have some of the best
That's
coverage in the
always a big
country.
question that we,
yeah, just about every one of our major insurance plans are picking this up, no problem.
Great. I have a couple of shout outs here from people watching.
Oh God.
Courtney's watching. Gracie's watching. Hi, Grace.
Hey, Gracie.
Keith is watching and says that he has COPD, which we will get on to talk about in a bit. And then Butch is asking about obesity. We mentioned obesity as a cause of asthma, but he said it's not the only cause. And so we did touch on that it is not the only cause of asthma. But certainly losing weight does kind of have a multifactorial positive effect on your breathing. So that's it. So feel free. I haven't heard from the St. Luke's ICU at all.
I'm sure that's probably a good thing.
Facebook.
Yeah, we don't.
Otherwise, hopefully they're working.
Kind of just other things with asthma, I think it's important to talk about. One of the common things that causes wheezing and can affect asthma is acid reflux, correct? I mean, we see a lot of people who coughing at night, and related to heartburn, believe it or not, or what people don't know about that. What's the relationship?
So there's a big overlap, and that's one of our comorbidities or our alternative diagnoses that we have to rule out or at least address and treat appropriately before you get down to the root of the asthma.
Yeah.
Asthma is very easily mimicked by acid reflux. Imagine your stomach makes acid all night long. Now lay down. And gravity is not your friend anymore when you're in bed, and it easily, in some people, comes up through the esophagus, and your esophagus and your trachea, or your food tube and your breathing tube, join at the top of your throat. And it's very easy to spill gastric contents or acid from one to the other. And as you can imagine, acid is very caustic to the airways and can cause a cough, can cause laryngeal edema. It can cause wheezing when it irritates the airways. I said the only thing the airways know how to do is squeeze. So if you pour acid into them, they're going to squeeze. So, I'll address acid reflux very aggressively in my patients. And even patients that don't realize they're having acid reflux.
You may not feel having heartburn, right?
Exactly. Right. Heartburn is the main symptom of acid reflux. I mean, some people tell me that they taste blood in their mouth in the morning. Well, that's a bad sign. Your acid reflux is out of control.
Or any time, really. Tasting.
Or even a sour, and I think everyone has a sour taste in their mouth in the morning, but then there's a seriously sour taste that they know is not normal for just I've been asleep all night with my mouth open. It's acid reflux is really affecting that really sour taste in the morning. And there are some people that feel heartburn, and there are some people that don't feel heartburn. We call that silent reflux. And it's almost 50%. And I have to convince people sometimes, no, you're having acid reflux. And they say, well, how do you know? I said, well, I've done a bronchoscopy and I've looked in the back of your throat and it's chewed up from acid.
And you can see it. So you can see
exactly.
the
I can take pictures and show them and say, this is what your airway looks like. And
we see that in clinic all the time. People who come in with cough or wheeze, and we'll talk about this next in terms of like the approach of people who should be coughing and why. And it's really interesting what you said, that they don't have heartburn symptoms. People who do have heartburn symptoms, it's great because they're
easy to convince.
Easy to convince.
I feel that. Exactly.
But the people who are not having symptoms, but
it's a harder sell to say try this for a couple months and see if your cough
what?
goes
You're going to treat my stomach, but somehow my lungs are going to get better. But it's amazing how quickly it works. It's kind of like we follow this decision-making tree in terms of things that make people cough, and acid reflux is one of them. And it's really rewarding in the sense of like it's a great fix, and they're so happy about. Oh my God, like Zantac twice a day, and I slept through the night, right? Like
So there are, I'll tell my patients that not all of our interventions are therapeutic. Sometimes they're diagnostic. And I'll tell them this is in trial and error sometimes. Take this inhaler and tell me if it works. If it works, we have a diagnosis. If it doesn't work, I got to go back to the drawing board. Don't be frustrated if that happens. It's the same thing with acid reflux. Say, take this proton pump inhibitor for a month and tell me if your cough goes away. Tell me if your breathing gets better. And if it does, it's easier to convince them that they're having silent reflux.
I think it's important for people watching the show and just making sure that it's not normal to cough for long periods of time. So if you have a cough that is not going away, lasting more than I would say, maybe we could talk about this 2 to 3 weeks. I would say that's just persisting.
Sure.
Worth getting evaluated, because it could be allergies, it could be maybe just some irritation, but it could be something more serious. God forbid. You want to make sure that it's not something uncontrolled reflux, or it's not emphysema or asthma or something. God forbid it's not the beginning of lung cancer. I mean, there are reasons. So
or medication side effects too.
I mean, medication side effects. It could be but. And I'd defer to you a little bit, Mike, on this in terms of
how do you navigate what's serious?
Or like when would you worry? In terms of like if you have a cough that doesn't go away.
Having a cough and upper respiratory symptoms, everyone knows what that feels like. That's normal. You don't need to run to the emergency department because your kid got sick and then you got sick and you've got a little cough and a little fever. That's going to get better on its own. You don't need a Z-Pack. It's almost always viral.
Wait, say that again.
You don't need a Z-Pack for every cough that you have. But that's the culture we're in. So most people know what the typical cough is from an upper respiratory infection. Coughs that persist are something you want to get evaluated. Coughing up purulent sputum or green, brown, concerning. If it goes away quickly, great. If it lingers, especially if you're having fevers, something you want to get checked out. Cough with shortness of breath. If you're having trouble breathing, or you can't do the things you used to do, you're walking on a flat surface and you're getting short of breath from here to there, and you're coughing, that's something you want to get checked out.
Outside of that kind of acute period of illness, if you have your kid sick in hand.
And I think it's safe to say, like what we try to tell our patients in terms of kind of understanding the basic timeline. So from a viral infection, 7 to 14 days.
Easily.
Right?
Easily.
And if it doesn't get better after that or it's worsening, that's worrisome, right?
Absolutely.
Like, sick, about a week, maybe 10 to 14 days, kind of coming back down and you're back on your way again, right?
Absolutely.
That's kind of okay.
Coughing up blood.
Not good.
Not good. You want to be seen for that. Okay.
Not waiting for that.
Not waiting 7 to 10 days.
Now, although most times
people,
time people cough up blood, it's because they've been coughing long and hard, and they're just irritating their airways, and they're getting a little bleeding.
And there is a difference. There's streaking of blood. Really
patients come in and say, "Oh my God, I coughed up a ton of blood." Well, what's a ton of blood to you? Because a ton of blood to me fills the coffee cup.
Right.
That's concerning. If they say it's a little streaked in my tissue, By the way, some people always like to show you the tissues.
Yes.
When they coughed up. Yeah, that's
and
most,
pictures are fine,
yeah,
too.
okay.
We don't need
Anybody
the actual
listening,
tissue.
if you come see me
Yeah.
in the office, do not show me what you coughed up in a tissue. A little blood into a tissue or less than a teaspoon of blood that's mixed with sputum is not as concerning. But still, you have to get it checked out
Yes.
quickly. I would encourage everyone to do
Anyone,
that.
no matter what it is, if there's
Yes.
blood,
If there's blood, go get checked out.
get checked out.
Okay. And yeah, that cough should definitely be evaluated. So it can be from reflux, people that have GI bleeds, gastric varices, esophageal varices, ulcers. It can be from nosebleeds. We see a lot of hemoptysis or coughing up blood fall in the nosebleed category. They lay down at night, their nose is bleeding, it goes into their lungs, they cough, boom, it's up. It's still from your nose. So actually, coughing up blood from your lungs is usually third on the list, behind your stomach and your nose.
Interesting.
Just throwing that out there.
But still
Other
get it
common
checked.
things that make people cough. One was, cigarette smoking is just notorious for,
Yes.
it also raises, if you are coughing a lot and you're a smoker, it actually you should be a bit more concerning for maybe something more serious could be going on.
Yes, it's good to get checked out. Absolutely.
For non-smokers out there, it could be, allergies, like you said, like postnasal drip can cause it a lot of times, so getting evaluated, sometimes as simple as using a nasal steroid spray, like a Flonase that's out there, or Zyrtec or treating the allergies can help people with it. The acid reflux we talked about, and then there's certain medications that are notorious for
Yes,
driving
ACE
people crazy,
inhibitors.
right?
Yep, lisinopril is the most common. I do get referrals constantly for people with chronic cough that are on a lisinopril, and it's a different cough. Those are more the irritating cough as opposed to the deep barking cough.
Yes.
Those aren't lisinopril
Almost like a
coughs.
tickle, they describe it.
It's a tickle that they just keep coughing all day long.
I saw a woman today who coughing is fine, and sure enough, it's on the medication list. And those medications are blood pressure medications. They often end in ills. You can ask your doctor about them. But the funny thing with those is people can be on them for years and years and years and be
then
fine,
develop it, yep.
and then all of a sudden they have this reaction, which is kind of a shame because they're great medications. And so,
Totally agree. So in chronic cough, we get a lot of referrals, obviously, for chronic cough. Primary care physicians do a great job, but you get to a point where you've done the basic testing and you haven't answered it yet. So you end up in a pulmonary office. And chronic cough, usually we look at the usual suspects. Postnasal drip, like you said, is one. Acid reflux is another. And asthma is third on that list. So someone with chronic unexplained cough, those are our top 3 diagnoses as well. If it gets beyond that, now we're talking a lot of intervention and bronchoscopy. And
we do, we often will do a chest x-ray at some point to evaluate to make sure, because it's simple, it's low, it's not expensive, it's low radiation, gives us a ton of great data. It's one of my favorite, our favorite tests. But talk about pulmonary function testing and what that, what that is a little bit, and some of the other resources that you have to evaluate lung function.
Absolutely.
It's great too, because we have these resources.
Sure. So pulmonary function testing is a time-tested tool of the pulmonologist and primary care physicians. It falls into, it's actually 3 different tests in one. It's a test called spirometry, which measures airflow in and out of the lungs, and the speed of airflow in, the speed of airflow out. And it gives us a sense of how narrowed those airways are at the different phases of the respiratory cycle. Then there's the lung volumes. It tells us how much air is in the lung at different points in the respiratory cycle. And last is the diffusion capacity, which is a measure of how efficiently your body takes oxygen from your lung and puts it in your bloodstream. So between those 3, we can get a really good snapshot of an overall lung function. Add into that a methacholine challenge, which there's not a test for asthma, but this is a good one to rule out asthma. A methacholine challenge is essentially having a patient inhale a substance that's not dangerous, but it'll piss off your airways. And you
So
inhale,
inducing that
it'll induce a
irritation.
bronchospasm.
Yeah,
exactly.
yeah.
So you breathe it in, you will get an asthma attack if you have
asthma.
If you have the propensity towards
To have
asthma.
asthma, yeah.
So just because everyone has a methacholine challenge that's positive doesn't mean they have asthma,
Okay.
but it means they have the propensity towards asthma. Now, if you do that to somebody and they don't react to it, there's almost no way they end up with asthma.
Okay.
So it's got a very good negative predictive value. The positive predictive value, not so much. Asthma is really a diagnosis based on symptoms and response to treatment.
Okay. And those, by evaluating how well the air moves in and out of the lungs and how well the gases go in between the lungs, it helps us diagnose another super common disease that patients may have, which is like emphysema, or sometimes also called COPD, chronic obstructive pulmonary disease.
Sure.
Talk a little bit about
The difference between
that
asthma
and asthma in terms of, because it really is, they're different diseases, right?
Absolutely. So It depends on which year we're talking in. COPD used to encompass asthma as well. Obstructive lung diseases are diseases in which air can get into the lungs easier than it can get out of the lungs. Now, how does that happen? Like I said before, with the airways, there's that floppy membrane on the back of the airways. When you breathe in, that actually bows out and allows air to come in more easily. When you breathe out, it collapses down, so the expiratory phase is always longer than the inspiratory phase. Although the expiratory phase is passive, the inspiratory phase is active. We're muscularly breathing air in, but it just kind of comes out on its own unless you're blowing it out. People with COPD have more inflammation in their airways. Well, let's define COPD real quick. Asthma is an obstructive lung disease, but we don't consider it COPD. We reserve COPD mostly for chronic bronchitis, emphysema, and something called bronchiectasis, which is a little outside of the scope of this. Chronic bronchitis and emphysema are almost always seen with smoke exposure. Yeah. Smoke, sometimes occupational, like I said, sometimes biofuels in the home, and very rarely genetic deficiencies, but almost always it's associated with smoking. Most people have an overlap of chronic bronchitis and emphysema, and I'll talk about what those are. Very rarely we see someone purely chronic bronchitis or purely emphysema. And those were the blue bloaters and the pink puffers that we learned in school. Yep. Exactly. Very rare to see one of those in their purest form. It's usually a combination of both. Chronic bronchitis is a constant hypersecretion of mucus into the airways. So these are the airways that get very boggy. They cough up a lot of junk every morning when they wake up. The airways are narrowed from an overall inflammation, not so much of the muscular layer, but of the endothelial layer of the airway that becomes very heavy with inflammatory mediators and cells.
So it's constantly producing
secreting,
the mucus. Yeah.
Exactly. Yeah. So these are the people that walk around and you've seen them constantly coughing up gobs of junk. The emphysematous patients, now everyone learned in high school probably, that the alveoli, or the functional unit of the lungs, looks like a bunch of grapes. Okay. And those grapes are covered with blood vessels. And what that creates is a lot of surface area for gas exchange between the alveoli and the bloodstream. There's a ton of surface area in a bunch of grapes. Well, imagine taking that bunch of grapes and turning it into a grapefruit. It can be overall the same size, but you lose a lot of surface area. And that's where emphysematous people, or the true pink puffers, end up having their trouble, is they have plenty of lung, but they've lost those alveoli, or the septal separations of the alveoli, the bunch of grapes, and turned it into a grapefruit, and now they just can't move oxygen back and forth. And the air gets in, and then it has trouble getting back out. Right. These are the hyperinflated lungs. The emphysematous patients actually are not, they don't even look like the chronic bronchitis patients. The chronic bronchitis patients are usually a little bit on the bigger side, hypersecreting, coughing. The purely emphysematous patients are the skinny, frail, muscle-wasting, very barrel-chested, constantly leaning over at a tripod to breathe. This is something everybody does instinctively when they become short of breath, and it's actually used to engage other muscles of respiration. Even if you don't know why you're doing it, you do it. So you always see these people tripoding, trying to breathe. You go see them in the hospital, and they're leaning on the table in front of the bed. You can walk in and diagnose them
right away. So how important is it in treating COPD to determine what, if the component, whether it's purely emphysema or if there's a component of chronic bronchitis as well?
Sure.
How important is that?
Very important. So again, these pulmonary function testing can give us an idea of that. The chronic bronchitis patients, we see a lot of airflow obstruction. And the emphysema patients, we see a lot of loss of diffusion capacity. And again, I say they lost that surface area, so getting the oxygen from the alveoli into the bloodstream becomes very inefficient. And these are the people that become hypoxic very quickly. Lung volumes, we typically see a lot of air trapping, more in the emphysema than the chronic bronchitis. The chronic bronchitis people can look almost relatively normal sometimes on pulmonary function testing, but functionally they are not.
And that's when the symptoms would be important in the diagnosis with the coughing and the
Exactly.
Okay.
Absolutely.
And in terms of like kind of symptoms that you may have to kind of tip you to maybe getting this investigated. If you are waking up coughing, bringing up mucus, right, like thick mucus, for prolonged periods of time, a couple times a year, is that still kind of a good guideline that maybe something could be going on, right?
Typically, yeah. If you're getting bronchitis symptoms pretty often, you're waking up in the morning, and all these patients describe, I get up and I have my smoker's cough, and I can't breathe, and I cough for half an hour, and I get it up, and then I'm fine the rest of the day. Well, that's probably not normal. Or you have bad postnasal drip or acid reflux. If you're getting short of breath doing things you used to be able to do, we ask people, can you carry groceries? Can you climb a flight of stairs? Can you climb 2 flights of stairs? Can you do all your activities of daily living? Are you getting short of breath walking around, walking upstairs, doing these things? That's a tip-off that over time, again, slowly these symptoms have kind of gotten worse and worse. And everyone loses lung function over time. So if you look at somebody's lung function on a curve, as you get older, you lose lung function. The good news is we have way more lung than we need. But people who smoke and COPD, especially the untreated COPD, their curve is much more steep. They lose lung function more quickly. Now, everyone has that point, their threshold. You don't feel it, you don't feel it, you don't feel it. You hit that threshold and boom, you have symptoms all of a sudden. Yeah. People with COPD feel that a lot earlier in life. Hopefully you died from something else of old age before you ever hit that threshold, and those are the people that
from the natural kind of decline.
From the natural decline, exactly.
Okay.
Yeah, and why cigarette smoking is so terrible, we were just reviewing this and just to make sure, but it's a constellation of things that it does. So one, it just makes our airways produce a lot more mucus than we normally do.
It's a constant irritant.
So it's constant irritating. It wipes out our lungs' ability to kind of clear out the mucus. So we all have this amazing ability in our lungs to kind of brush and clear the mucus.
Absolutely.
These hairs, so people know. And then, so smoking kills them. So then there's more mucus and there's less ability to clean it out.
Absolutely.
And then just exactly to your point of like we all have this natural decline as we age with our lungs, but cigarettes accelerates that, correct?
Very much so.
And then help breaking it down. And so that's kind of what the cigarettes do in terms of the damage to the lungs, right?
And when I tell my asthmatics, especially who smoke, cigarettes almost render you immune to your inhalers.
Yeah.
So cigarette smoke and inhaled corticosteroids essentially negate each other. So if you're using Advair, Symbicort, Flovent, whatever your inhaled corticosteroid is, and you're smoking at the same time, you're doing nothing for yourself.
Right.
And it's important for people to know, like, stopping smoking is significant. Like, it's not like the damage is done and, oh, well, might as well keep doing this, right? Probably the number one treatment first is quitting smoking, right? In terms of stopping the progression of the disease and maybe even getting better, right? In some ways.
So we don't ever get our lung function back that we've lost, but there is described the honeymoon period where after you quit smoking, the pulmonary function testing does show an improvement in that first year. What it really does, though, is puts people back on that natural progression of loss of lung function. So they go from that very steep decline to that more soft decline over time, and hopefully hit that threshold a lot later than they would have normally.
Yeah. And we definitely plan on the upcoming show to talk about smoking cessation. I think there was a show a while ago before Hannah and I took over, but great topic to talk about. Lots of good options for people to try to get them to quit smoking. Not easy to quit smoking. We absolutely appreciate, but
we have a great question actually from Nancy, who her first comment was that she's so proud of you, Dr. Barretti, and how you care for your patients.
Oh, thank you.
Nancy Armorall, and she's asking for the younger generation. How does vaping affect healthy lungs? Do you have any, is there any data on, people are stopping smoking cigarettes, but now turning to e-cigarettes and
hot topic.
Vaping, right.
Hot topic.
Right.
Hot topic. I can tell you there's the medical literature on vaping, and then there's the common sense on vaping. Is it good for you? No. Is it not bad for you? No. It's probably bad for you. Okay. We don't know exactly what you're inhaling when you vape. It is a lot of chemicals that you otherwise would not be inhaling if you weren't vaping. Practically speaking, I feel it's probably not as bad as smoking. So if someone had to do one of the two, I would probably prefer they vape as opposed to smoke. But I can't endorse that either because there's just not enough time and data and literature on what the long-term effects of vaping are. I can tell you that we've seen an uptick in aspergillosis and other interstitial lung diseases, which are disorders of the lung tissue itself, from vape exposure. And
those are much harder to treat than
asthma
and COPD.
Absolutely. Those require a lot more invasive diagnostic testing and a lot more invasive treatments.
Okay. And I think we had heard a presentation actually last Wednesday about kind of the how smoking marijuana, one marijuana cigarette, it equals, what did we hear, 20, or three to four marijuana cigarettes maybe is equivalent to about 20 tobacco cigarettes, or do you have any?
Much more potent.
The
presentation was that with the typical marijuana cigarette that you are holding it in your lungs for much longer periods of time than smoking, you know what I mean? And the level of damage that can do to your lungs is much more significant than cigarette smoking.
So yeah, and this is something that people do need to understand, because there's a whole generation of people who believe that it's natural and I'm not doing anything bad to myself by smoking it. This is not my personal feelings on marijuana use. To be quite frankly, if you want to use marijuana, go get edibles. Okay?
Yes.
Especially if you have an indication for medicinal marijuana.
Yes, I think there's emerging data that is, right?
Go get edibles.
Yes.
I think that's fantastic. But smoking marijuana, no, it's not safe. Number one, you hold it in your lungs a lot longer. Number two, there's no filter. Yes, there's no exogenous chemicals that are put in by a company, but I'll tell you what there is. There's mold. And when you buy tobacco prepackaged from Philip Morris, you're probably not getting aspergillus in your tobacco. You're getting a lot of other things you don't want.
Right.
But in marijuana, we've seen a huge prevalence of pulmonary aspergillosis. Aspergillus is the most common mold in the world. It happens with any decaying organic matter. So if the flowers dry out on your coffee table, they are growing aspergillus. And if you're not immune compromised, your body doesn't care. If you are immune compromised, it's a huge issue. If you smoke those flowers that are dying on your coffee table, you're going to end up with aspergillus in your lung. And marijuana is no different. These are dried out, partially decaying organic matter plants, and you're smoking it, and you are going to have a higher incidence of this very severe fungal infection.
Great points. Yeah, I think we feel the same way, that I think there is valid and real benefits to medical marijuana therapy.
Absolutely.
But just smoking is not good.
Not
smoking anything, just not.
I would tell all of my patients, if there's a way, if you need medical marijuana, if you even want to do recreational marijuana, that's your choice. But I would always rather people use edibles or
or oils or tinctures.
Oil, exactly, something that's not smokable.
Good. Hannah, any questions in the queue? Are we all caught up? Awesome.
Oh, that's great.
Michael, any other parting thoughts, comments?
No, I want to give a shout out of my own to Boston Scientific for helping us out with the bronchial thermoplasty program. They've been a great partner in getting this program set up here, and this is the only bronchial thermoplasty program between Yale, New Haven, I believe, and Boston.
What a resource.
It's huge, and especially in this area with the prevalence of asthma, and with a higher prevalence of asthma, we have a higher prevalence of severe persistent asthmatic patients. And we're looking more to bronchial thermoplasty even before the biologics, which are monthly injections of pretty nasty agents sometimes, and sometimes a one-time treatment is more indicated.
Good.
And I'm doing a talk.
Wednesday, June 27th, correct?
Yes, a patient education session at the Fairfield Inn and Suites here in New Bedford. There's a phone number to call if people want to register for it in advance. It's 888-777-1493.
So open to the public, patient education about asthma.
About asthma and about bronchial thermoplasty as a possible treatment, and really we can just talk about asthma in general. And a good patient education session starting at 6 o'clock.
Great.
Thank you very much for taking
the time
out of your very busy schedule.
No, this was great.
Yeah, thank you for all you do for our patients too, and we're lucky to have you as a resource for them to see. We want to say one more final thanks to all EMS personnel for all the services they provide to our patients.
Absolutely.
And their invaluable service to the Southcoast Hospital Health System Physicians Group in our community. So thank you very much. And want to thank Josh, our producer, for helping us put on another great show. Thank you for everyone who wrote in for the questions and for just engaging with us. We really appreciate it. And we will see everyone next week. Stay healthy, Southcoast.
I had 2 blockages. I had to have a catheterization, and told me that we needed to see a surgeon as soon as possible. Dr. G made me feel like I was his only person that he ever did surgery on. You don't have to go to Boston. You can come right here to Southcoast and get the best treatment. I said to him, Dr. G, I guess I'm going to fall in love with you. He says, I know I'm going to touch your heart.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into a 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, throw it out of your vocabulary.